So now we're going to move into the second part of this plenary and more focusing on different phenotypes. The topic for our talk will be non-sitters across the lifespan, and I will do this talk in conjunction with Dr. Leslie Nelson. I will initially focus on the more clinical components of this, and then later on she's going to be touching base on the results of treatment in the real world for this group of patients. These are our disclosures. So, you know, when you look at SMA, particularly this is for the people that are still getting to know more about this condition, you can get into this old classification of SMA, where they are like the clinically defined 5 types, ranging from most to less severe, as you can see. The most phenotypic determinant, as you heard before today, is the SMN2 copy number, which is inversely correlated with disease severity in most cases, as we have heard on prior presentations today. But as you have also heard, not all SMAs are the same. And then, for instance, there are patients that have similar, some variants that will make this phenotype less severe. The topic of our talk today will be to centralize on the evolving phenotype of the non-sitters in the therapeutic era. And then that, you know, if you look at the old classification, mostly will focus on the patients with a more severe phenotype, as you are seeing here. Without treatment, individuals with the most common form of this disorder, known also as SMA1 or SMA0, never gain the ability to sit or stand and usually die or require permanent ventilation within the 2 years of life. Standardized care, though, even before the era of these new treatments and the guidelines, have helped reduce the mortality of SMA type 1 and 2 by pretty much 30% depending on cases, but nearly half of these patients still are or were in dependent on non-invasive ventilation and feeding support. So despite the wide use of previously shown classification, the development of a new treatments has made some of these shortcomings of this classification apparent. And in the last 10 years, as you've been hearing on the prior plenary session, the development of the therapeutic strategies has increased the SMN levels that has changed SMA from a progressive, frequently fatal disorder to a more chronic condition in which the motor disability could be halted, and in those cases where treatment is initiated, even in the pre-symptomatic patients, as Dr. Finkel was mentioning, individuals should prevent this course of the disease. So a more practical classification to accommodate new understanding of the natural history is to use the functional status as the initial evaluation and modify it accordingly as the patients evolve. This approach was used, as you heard also during this presentation today, by the standard of care document in 2018 to guide the supported management of these patients. So again, we will focus on this group. So despite the prolonging survival, these therapies often fall short of complete phenotypic rescue, especially when the treatment is initiated after the onset of symptoms, making the creation of a newborn screening programs a must in order to identify patients as soon as possible and in turn treat them accordingly. However, with that said, pediatrician vigilance is particularly important now because not all the states have newborn screening, and also many parts of the world don't have this available, and we know that we have audiences for all over the world, but will also remain important once it is implemented in all states and hopefully worldwide, that the newborn screening will only pick up about like 95% of patients with SMA. As this is going to be talking more detail later on, but as you know, newborn screening only detects the SMN1 deletion, and a patient that have other type of mutations, such as portogenic point mutations, might not be picked up throughout the screening. So if the suspicion for SMA remains, or the patient develops in a patient with a negative newborn screen, it is imperative for the pediatrician or the neurologist to send further genetic testing. So who then will be classified within this non-sitter category? So we came up with this definition as that it will involve all the SMA who either have now achieved the ability to sit independently or have lost this functional capacity over the years. But even within this group, as it was briefly mentioned on the other talks, it will be important to see that these patients will not be an homogeneous group. We will have to take into consideration the initially predicted type based on the age at presentation and SMN2 copy number, the type of initiation, the time of initiation of treatment certainly, and the type of treatment as well, understanding that they might be patients where they will be in single versus combination therapies. And then also, as it was mentioned during the previous talk as well, how to identify which patients are responders versus not responders. So here I would like to focus the attention to the clinical presentation, and for some of you who are in this audience and starting to treat these patients, I hope that this is useful, although this might be somewhat irrelevant for people that has been treating patients with this condition for many years, so I apologize for that. But clinical suspicion of SMA should arise in the hypotonic infants and individuals at any age with symmetric, predominantly proximal pattern of weakness. Here I would like to show you some of the most common presenting features, as you will see in the first videos. Oh, for some reason, my videos are not showing at this time. I apologize for that. But basically, these patients have presented many times as floppy infants with global hypotonia, areflexia, and muscle weakness that is characterized in the legs more than the arms with a classic frog-like position. The patients have poor heart control, or they lost that as they are developing, with paradoxical breathing pattern, bell-shaped chest deformity, valvar weakness. As you see here, there's a nasogastric tube. Early contractures, and these patients historically were not able to sit unsupported. This certainly has changed with treatment. But this condition is progressive, or used to be progressive before the era of treatment. So with the current treatment options available for patients with SMA, early consideration of SMA in any infant with this presentation should urge the referral to a pediatric neurologist or neuromuscular specialist. For most cases in by pediatricians, referral to therapy can provide significant and sufficient benefit, but urgency on the part of the pediatrician can ensure that all infants with SMA are treated as soon as possible. So here I wanted to show you, just to illustrate two examples. I believe that the videos, unfortunately, are not playing, but these are examples, going back to what there was a question from Dr. Day in the prior plenary session, what happened in real life. So the first case here illustrates this 3-year-old female that was born with 2 copies of SMN2, and she was diagnosed at around 2.5 years of age. Her baseline CHOP intent was of 17, and she was started nusinersen, which at the time of the diagnosis, about like 2 and 3 months of age. Unfortunately, during the loading low doses of nusinersen, she developed hydrocephalus. So it was always unclear with her, when we were only having one treatment available, how much of the nusinersen was reaching to the target cells. When Zolgensma opened with the extended access program, we were able to give her that treatment in combination. So even if we don't have, again, information of how these patients are going to do with combination therapy, or whether that is indeed needed, we decided to include this patient in the access program for Zolgensma. And now on the last evaluation with her 3 years of age, you can see here how she has improved not only her CHOP intent, but the hours on ventilation. She used to be 24/7, and now she's only requiring 11 hours or non-invasive ventilation. Here I want to illustrate a different example where this patient, unfortunately, at the time of diagnosis, there was no treatment still approved. She was severe enough that she didn't make any of the clinical trials at that time, but we were able to treat her at 10 months of age when the extended access program for nusinersen became available. And she started with a very low CHOP intent of 4. And then on the last evaluation, remember this patient started to be treated at 10 months, she's 4, she only improved by 12 points. This is remarking on one end the importance of early treatment and recognition of these diseases now that we have different treatments available, but also the fact that, if you look at different series, same patients that were treated at 10 months maybe have a different outcome and doing better despite sharing the same 2 copy numbers, showing like there's more variability besides what we are seeing. And here we are seeing the videos. Here in this patient, she's able to talk and communicate with the mouth, something that we were not able to see in the past with patients with a classic SMA. And this patient, despite like her limitations, she can play and be more interactive. This is another case that I wanted to illustrate from real life, where this patient presented with a very severe form of SMA, where we classify a type 0-1 because of early presence of contractures and symptoms in the newborn period, although the patient didn't get to us until he was 3 months of age when he was diagnosed. He had, though, 2 copies of SMN2 despite his early presentation, and he was started on nusinersen. He did improve his CHOP intent score at time points, showing a 3-point total score improvement from the time of dosing until the last evaluation at 23 months of age. And unfortunately, this patient passed away from sudden death. It's still unclear because there was not a precedent respiratory or cardiac problem that motivated the cause of his death. But just to emphasize how, these are very severe phenotypes that with the time only will tell us whether the expression or the clinical presentation is somewhat different from what we classically have seen in patients with SMA now that they are treated. And these are in part the lessons that were learned because, he posed an important question to us at the time of presentation, whether despite his severe phenotype, we decided to go ahead and treat. And then this patient did show some improvement. So this, you have seen this already in terms of the guidelines of treatment, and I encourage you, for the ones that are not familiar with this, to go ahead and read these 2 manuscript guidelines published in 2018 about the multidisciplinary care. And you have heard already about the approved disease-modifying therapy for the disease and how that applies in the US and Europe in a different way. And then the importance of the newborn screening available in different states in order to identify these conditions early. So this concludes the first part of the presentation, and I would like to pass into Dr. Nelson, who will go over the data from real world and effects of treatment on non-sitters across the lifespan.
Thank you very much. So now that you've seen a little bit of natural history before disease-modifying therapies, we wanted to give you a little bit of an insight into the background of natural history in respect to function. And so this is a couple of studies from natural history. Steve Kolb and his group, the NeuroNext group, conducted a prospective longitudinal natural history study that looked into biomarkers in SMA in patients that were younger than 6 months of age. The majority of those patients did have 2 copies of SMN2. And what they found was that those patients really scored a maximum of about 33 points on the CHOP INTEND. And then over time, they saw a rapid loss of motor function over the first 6 months that they were followed, that then continued over the next 2 years. Dr. Finkel in the PNCR group also reported on a cohort of patients that found that an average decrease of the CHOP INTEND was about 1.3 points per year in infants with SMA type 1. So again, just an understanding of motor function, and now to look at that in comparison with some of the information that you've gotten a glimpse into already this morning, in that the ENDEAR study looking at the use of nusinersen in our infants and non-sitters found that the latest data that was presented by Dr. Finkel at Cure SMA earlier this year shows that those treated earlier do have the greatest benefit, but those that initiated treatment later in the disease course still show some increase in the motor function over time. So from the ENDEAR data, we've seen that a mean change in the CHOP INTEND has been about a 17-point improvement, and 64% of those patients or subjects have obtained the ability to sit without support. In the STRIDE study, this was the gene therapy study, 95% have achieved a score of over 40 points on the CHOP INTEND, which is not a score that would typically be achieved based on our natural history data. Almost 60% of those are also able to sit without support, and this information was reported by Dr. Day at the MDA Clinical Conference earlier this year. Next. So Dr. Servais presented data at the World Muscle Society in October of this year, in which he reported the Firefish patients, the risdiplam placed patients. 90% of those saw an improvement of at least 4 points on the CHOP INTEND, and 57% have scored at least 40 points. And of those, that cohort, 33% were able to sit unsupported. Okay, next slide. So we have a little bit of understanding from our trials that looked at pre-commercial availability in these drugs, and now we have data that on patients that were treated commercially, mainly with nusinersen because it's been out on the market for a longer period of time. And so we're happy to kind of share those positive outcomes that we've seen from that real-world data. From this paper published out of France, it looked at changes over 1 year in patients that were younger than 2 years of age. They found that there were significant improvements in the Hammersmith Infant Neurological Exam, Section 2, for most all of the items. They also found that there was a mean increase from 35 points on the CHOP INTEND to 50 points on the CHOP INTEND in those patients. And then I think it was interesting in the study that they also included a caregiver rating. The ratings were a scale of 1 to 4, 1 being the caregiver felt that the patient was very much improved, a rating of 4 being that there was no change or no observed improvement. And you can see that 6% had that rating of 1, a very much improved, considerable improvement. 46% considered that the patient's condition was much improved, or a rating of 2. And so there are some subjective information that tells us that there are some improvements in these patients as well. Next slide. So Dr. Servais and his group found in this study in patients that were aged 18 to 113 months, there were similar benefits reported from the SHINE protocol, but they also reported in patients as old as 8 years of age in non-sitters that had benefits from the treatment. 5 patients, or about 16% in this cohort, acquired the ability to sit unsupported for 30 seconds. In the patients that were younger and the HINE 2 was conducted, they found in this study that about a 1.5 point improvement after 6 months of treatment occurred on average, or I'm sorry, based on the median. Okay, next slide. Dr. Mercuri and his group in Italy found significant improvement of 2 points or more on the CHOP INTEND in 62% of the patients in their cohort. And so these were patients that were aged 2 months to 15 years and 11 months of age. And their CHOP INTEND 12-month changes ranged anywhere between losing 6 points to gaining 32 points. The HINE 2 had change range between losing 3 points and gaining 12 points. And so while there was a range, there was definite improvement in the majority of these patients. And among this cohort, 16 patients gained the ability to sit independently. Okay, next slide. Also out of the Italian group, Drs. Mercuri and Bertini published data on respiratory status in patients with type 1 and found that overall there was an increase in survival as compared to the natural history. And then what I think is interesting is that 3 of these patients actually had a reduced need for ventilatory support over time, which I think is a very positive outcome. Next slide. Interesting enough, we've also found some predictive factors as well. So in this study that was published earlier this year, it was suggested that their higher baseline motor function and also improvement in the HINE 2 by more than 2 points may indicate that the patient will be 3 times as likely to achieve independent sitting. And then lastly, the next slide, this was a study done in non-sitters with an older cohort where we have a challenge in assessing motor function in these patients. But what was reported is subjective improvements that were published. And in these patients that were aged 12 to 52 years, 8 out of 12 reported having increased endurance, increased fine motor and hand strength that lent to improved independence and ability to perform ADLs. And then 5 out of 12 reported louder and clearer speech. And so I think that that will lend to, as we discussed in our breakout sessions, some of our outcomes and things that may need to be addressed and looked upon in our changing phenotypes. And now I'm going to pass it back over to finish up for the last couple of slides.
Okay, so I hope you don't get dizzy with this back and forward, but this is going to summarize some of the things that we wanted to emphasize on our talk today. The importance of the continued standards of care, because as you know, despite the prolonged survival, it is feasible that the new therapies fail to completely rescue the phenotype. At least for now. More information is needed to help guide clinicians for those patients who are eligible for multiple treatment, and if they are, as that was brought up earlier. The cases that I showed today, that in 2 of those, they did have combination therapy, is because they were born or were young enough to, take advantage of these extended access programs. But we know that reality will tell us that, once those extended access programs are not available for some of the newly approved drugs, the families might come to us willing to be not in 1, 2, but sometimes even 3 treatments. And it's our responsibility to identify what are going to be the measurements and the markers to decide who gets what. We know that the standards of care alone results in longer survival and better quality of life. And it's important, as we get excited talking to our new patients and families about these treatments, that we emphasize this concept. I think that is not longer a question that the addition of rehabilitation and therapy makes a difference, and we're going to see that more in our breakout sessions today, and that the continued multidisciplinary care for individuals with spinal muscular atrophy is essential. We still have a lot of challenges. Sometimes I feel that we have more questions than answers, but this is good. This is a good timing. We need to define different types and within the category of the non-sitters. For that, I will agree with Eugenio and Richard Finkel about the need of better biomarkers for each groups, not only including the SMN2 copy number, which is still helpful, but it's not something to be considered alone. Because with disease-modifying therapies, that might not longer predict the same phenotype as in the untreated patient classification. And other outcomes to validate change will be subjective, the importance of patient-reported outcomes. I'm very eager to see the patient session at the end of our meeting this week, the pulmonary function, but not only focusing on non-invasive ventilation and survival rates, but also number of hospitalizations, time of functioning, because this is something that changed the quality of life for this patient. Pay more attention now, our patients with SMA1 are talking, so how are we taking care of the voice, the speech production, the chewing, the swallowing issues that it might be still present in patients that have been treated through the newborn screening. They are strong and they are making milestones. But again, if you look in detail, they might not be doing the same process that we'll expect with a normal child. And later on, aspects such as for fine motor function, fatigue, and certainly the scales for adult patients. So with that, I think that we are done with our talk for today. I thank you very much for the attention. I apologize for the speed because it's a lot to cover, but we will be happy to take questions if we have time now or later on.
I think we're going to run right to the breakout sessions, Caro, just in the interest of time.